All right, hello. Welcome to part 2 of spine pathology. We're going to continue part 2 with some more cervical spine fractures that I'd like you to be familiar with. Jefferson fracture is a fracture of the anterior and posterior arches of C1, and it most often occurs if a patient lands abruptly on their feet or their head. And it's actually considered a comminuted fracture, which remember means you're splintered or crushed into multiple pieces. The anterior and posterior arches of C1 are fractured as the skull slams down onto that ring. The AP open mouth projection and a lateral C-spine projection will best demonstrate this fracture, but let's be real, they're going to go right to CT for the best images, and that's what you can see here. So here's the dens. So here's the anterior arch of C1, here's the posterior arch of C1, and you can see there's several fractures here. Okay, next, odontoid fracture. So an odontoid fracture, of course, involves the dens, and it can actually extend into the lateral masses or the arches of C1. An AP open mouth projection will best demonstrate this odontoid fracture, but again, this patient's going to go right to CT. You can see here, there is a fracture of the dens here, and unfortunately, this is a life-ending cervical fracture here with C2, C3 being involved. So, odontoid fractures are easy to remember because of the name odontoid. So it's a fracture of the dens. Okay, a teardrop burst fracture. So a teardrop burst fracture is a compression injury to the vertebral body, and it's caused by hyperflexion. The vertebral body actually experiences a comminuted fracture, so there's multiple fragments of the vertebral body, and they can be displaced anteriorly or posteriorly. And the problem with posterior displacement is that those fragments can then pinch or press on the spinal cord. That results in neurologic damage. Patients with teardrop burst fractures can, as a result, become a quadriplegic, for example. So you could certainly do an AP and a lateral cervical spine here, but again, patients with cervical spine fractures are going to go right to CT. By the way, before CT was widely utilized for cervical spine fractures, anyone with a trauma would have a lateral C-spine image done first. And you can kind of understand why after looking at some of these injuries. A lateral projection shows really nicely any obvious fractures or disruptions to the vertebral column. And again, nowadays patients are going right to CT. Once the initial trauma has been demonstrated in CT, certainly MRI is a really good modality for following up on those spinal cord injuries. Okay, so I want to transition away from cervical spine fractures and talk about a few more pathologies involving the lumbar spine. And we'll begin with spina bifida. So in spina bifida, the posterior aspect of a vertebrae doesn't completely fuse, and the meninges and spinal cord can be exposed posteriorly on the exterior surface of the back. This most often occurs at the level of L5, and it can result in paralysis. Okay, so you don't have to write this part down, but I wanted to talk a little bit more about the meninges. So if you recall from A&P, the meninges are 3 membranes that surround the brain and spinal cord. And in mammals, the meninges are the dura mater, the arachnoid mater, and the pia mater. Cerebrospinal fluid is located in the space between the arachnoid mater and the pia mater, and that space is called the subarachnoid space. The primary function of the meninges is to protect the central nervous system, and it's thought that a diet rich in folic acid would help prevent spina bifida. A woman who is planning a pregnancy should take folic acid for at least 3 months before conception and then continue that folic acid during their pregnancy. And again, in spina bifida, you have a protrusion of the meninges through the skin, and it actually forms this fluid-filled bulge called a meningocele. And you can see kind of an enlarged diagram here. Okay, so basically, just please remember that spina bifida is the failure of the posterior vertebrae to fuse in the lower lumbar region, and it's present at birth. Okay, spondylolisthesis. Spondylolisthesis is commonly due to a defect in the pars interarticularis, which remember is part of the lamina in the lumbar vertebrae, and it's the neck of the Scotty dog. And you can see an example here where there's kind of a defect or a break in that pars interarticularis. Because of that, one vertebral body will slip forward over the vertebral body below. And in this case, you have L5 slipping over the top of the sacrum, or S1. And that is the most common site for spondylolisthesis to occur. Treatment for spondylolisthesis is typically a fusion of that site to regain stability. Okay, last pathology that I want you to know is spondylolysis. And in this case, there's also a defect in the pars interarticularis, or the lamina of a lumbar vertebrae. This is most often seen, though, as a result of an injury, and it's actually called a break in that neck of that Scotty dog. And so you might see this type of injury in like an athlete that's had an injury during a sporting event, for example. So you can see here in this x-ray, this is the break of the neck of the Scotty dog, or the pars interarticularis. And they've drawn that here for you as well. The difference between spondylolysis and spondylolisthesis is that in spondylolisthesis, you have a forward movement of the vertebral body. In spondylolysis, you do not have that forward movement of the vertebral body, but it is a pars interarticularis defect. So that's all I really want you to differentiate is in one, you have forward movement of the vertebral body, in the other, you do not. Okay. All right, we're going to pause here and conclude our spinal pathology lectures. If you have any questions, please let me know. And certainly we'll practice with this content once we get to class. Thank you.